Thank you very much. I thank Mark for the kind and intimate introduction. Also, Professor Mark Manis, I think, give some of the introduction as well. And Enzo and the organizing committee of the SICSSO, I think I'm very honored to present some of the things I've been working for the past 13, 14 years or so. So that is the expansion of the human corneal endothelial cells and use this for the transplantation injection into the anterior chamber. Well, this image was taken the 4 months after the cell injection in patient with the total bullous keratopathy. You can see some of the clumps and also massive endothelial cells on the descemet membrane. These cells are coming from the injected, the cultivated endothelial cells because this is a totally bullous keratopathy. This is not the Fuchs endothelial corneal dystrophy. I have several financial disclosure to make, but this talk, there's no relation to these, the companies or so. So I'm talking about the bullous keratopathy. In Japan, we have some Fuchs endothelial corneal dystrophy, but we are mainly dealing with the bullous keratopathy with the, after the surgery such as the glaucoma or the cataract surgery or vitreoretinal surgery or so. So I think our primary goal is more like a severe type of the bullous keratopathy. So we've been proposing the cell injection therapy using the allogenic cells. These cells are coming from donated cornea that remove something on the descemet membrane, inject the cultivated endothelial cells with the low kinase inhibitor solution and face down position for 2 to 3 hours. Conceptually, one donor cornea can create over the many cells for at least for the 100 patients, and also the safe and speedy procedure. So because we use the allogenic human corneal endothelial cells, you may have some kind of fear to use these cells because this is allogenic. This is not autologous cells. So therefore, we perform the one animal experiments using the mouse. So that is take the mouse corneal endothelial cells, inject these cells into the anterior chamber or the vein. So, and then what we have found is the no allo sensitization occurred, and also immune tolerance is induced. You may know the Wayne Sterling proposed the idea that is arcade, anterior chamber associated immune deviation. But not only for that, immune tolerance are induced and there's no allo sensitization occurred. So that means that we are safe enough, at least we are safe enough to use these allogenic corneal endothelial cells for cell injection. So far, we have performed 35 cases. We haven't seen any endothelial rejection after the treatment. So this is one example of the corneal endothelial function recovery by the cell injection therapy. You can see, because we only add the cells, no tissues, so therefore the cornea become quite transparent, but the optical quality is an excellent, just back to the normal. So the goal is to obtain a high corneal endothelial cell density also with good physiological function. Well, this is just one example of the cultured corneal endothelial cells for cell injection. This is lot C23, P3, passage 3, from 3 days to 47 days. You can see this is 3 days at the CPC center. You can get some image of the what kind of cells we are injecting into the human eyes. This is the 47 days. Well, this is the image of the OR. These cultured endothelial cells make the cell suspension about 6 or 5 hours, 5 to 6 hours before the injection. And my assistant, Dr. Okumura, he's now making the 300 microliter of the solution. They are supposed to contain 1 × 10⁶ cells. And then this is the no dead space syringe. That's a special syringe. So that's why we can exactly inject 300 microliter. So this is the one example of the video, 1.6 millimeter corneal incision, and the tip is a silicone. So we try to scratch. At this point, this is a protocol. So therefore, we try to scratch something on the descemet membrane, ECM or the damaged endothelial cells or so, up to 80 millimeter in diameter, because we'd like to compare the endothelial cell density afterwards. So, and then using the vision blue, and we try to see what area I scratched off. And then use the one stitch at the site of the incision, and then we pump in and pump out the rho kinase inhibitor solution that could enhance the attachment of the injected cells or so. And then finally, we removed all the aqueous humor from the anterior chamber by 30 gauge needle. And then we inject the cells. In this case, we use 25 gauge needle because otherwise 30 gauge needle will destruct the endothelial cells, the suspension. So therefore, we use 25 gauge needle, 300 microliter, and then immediately after the cell injection, the patient hold the face down position or so. Total procedure is about 10 minutes or so with the topical anesthesia. So immediately after that, the patient holds face down position, and there are a special bed, and we can also prepare the iPad. They are supposed to have a video and the movie, and the patient already selected that movie. If the other eye is healthy, she can see the movie or so. So then during that time, the endothelial cells, they are supposed to sediment it on the descemet membrane. So this is 4 months after the cell injection. You can see there's no uveitis or no inflammation or so. So I think the cornea comes back to almost a normal. So we have performed the clinical research under the clinical guideline followed by the role of the regenerative medicine in Japan. That is set up about a couple years ago. So, and then we divided the three groups into three groups. Group one is we try to see the safety and efficacy test using partially mature cell. E ratio is under the 90%. I would like to talk about the E ratio later on. 11 cases. About 1 month ago, we just fixed the data. Group 2 is a efficacy testing using the mature cells. E ratio is over the 90%. And then 7 cases, that is still running. And then group 3 is, we try to broaden the indicative diseases, such as the bullous keratopathy with the BREP formation or the some of the after the corneal transplantation failed graft or so, 17 cases, that is still running. So this is just one example of the first 3 cases. This surgery is performed the 2014, just over the 3 years ago, a 58-year-old male. This is a Fuchs endothelial corneal dystrophy. You can see pre-injection 1 month and 6 months, best corrected visual acuity become normal, and central corneal thickness. This image is obtained by the pentacam, and then you could get some of the image of the decreasing the corneal thickness. That means a functioning of the endothelial cell. So this is the first 11 cases of the data, especially if you could compare the surgery of the corneal thickness and the post-corneal thickness 6 months after that. You can see most of the patients did show the less than 600 micron, and also the visual acuity is improved or so. So this is a picture of the case 1, case 2, case 3, 4, 5, 6 or so, preoperative, I think, a pentacam image, and 6 months after the pentacam image. This is a 7, 8, 9, 10, 11, and the 12 or so. You can see we haven't lost any any case after the cell injection procedure. All the cases maintain the corneal transparency, but the longest one is still the 3 years. So we are still not so sure for the long-term basis of the corneal clarity. So this is the initial 11 cases. First case at 6 months, we only got the 947 cells per square millimeter or so, but the another 10 cases shows either the over the 2,000 or the over the 10,000 cells per square millimeter or so. The data is almost comparable or maybe a bit better than DSEC or the DMEC procedure. So this is a kind of summarized result of cell injection therapy, best corrected visual acuity and corneal thickness. Corneal thickness under the 650, that is about 4 weeks after the cell injection we could obtain. But corneal epithelial edema is already disappeared about 1 week after the cell injection. So I think this is also quite reasonable. And then what about the safety? This is no increase of the intraocular pressure so far, except for the steroid-induced glaucoma. And then no immunological rejection or no uveitis or no infection. So I think I would say that specifically regarding this type of the surgery, we haven't seen some major the problem or the adverse effects or so. So this is very interesting because a 77-year-old male graft failure because of the immunological rejection after the penetrating keratoplasty. So we wait about a couple months or so, and then we perform the cell injection into the anterior chamber, and you could see the cornea immediately become transparent with a high corneal endothelial cell density. We use the steroid eye drops, but not immunosuppressives, but still the cornea maintained quite transparent. So I think that this procedure may be quite beneficial after the graft failure of the PKP, and also we have performed this surgery for the failed graft of the DSEC procedure as well. So this type of the surgery, the equal quality of cell products is a key for the regenerative medicine. That if we trust the cell products is equal quality, and then we can evaluate the safety and efficacy issues as well. So when we culture the human corneal endothelial cells, they are heterogeneous. There are at least 4 or 5 different kinds of the endothelial the cells I think observed. So among them, I would like to introduce the fully differentiated cells into the anterior chamber. There are several reasons, but these are the mature, fully differentiated endothelial cells are safe enough to inject the cells, but not the other one. Because the picture, these cells are CD44 negative. The other one is CD44 positive. The CD44 positive, if so, these cells tend to show like sex chromosome deletion or trisomy occurs. So I think I would say this is a bit dangerous. But CD44 negative cell did not show any abnormality of the chromosome and also other factors as well. So therefore, we try to evaluate what's the matured endothelial cells. Matured endothelial cell regarding cell surface markers, CD24 negative, 44 negative, 26 negative, 105 negative, these cells. And we try to increase the number or the proportion of these cells in the culture. So the E ratio is the proportion of the cultured endothelial cells highlighted on blue. So we now have over the 90% of the cells, they are supposed to be highlighted on the blue. And then we compare the sum of using the sum of the cases, the mature cells is under the 70%, or the mature cells is over the 90%. You can see the case 9 is under the 70%, and then the other one is the case 16 did show over the 90%. Endothelial cell density is completely different, and also the shape is different, although cornea become transparent in both cases. So when we compare these like a group 1 and group 2 is higher E ratio. E ratio, at that time, the endothelial cell density is over the 3,000 cells per square meter. Maybe that is too much because we inject 1 times 10 to the 6, but we may be able to decrease the amount of the cells 5 times to the 10 to the 5th or so. Because now when we calculate how many cells are supposed to be on the desmoid membrane and in a normal subject, that is about 1 to 2 times 10 to the 5th. So even though we inject 5 times 10 to the 5th, that is about the double of the cells we injected into the anterior chamber, if all the cells attach to the desmoid membrane. So we made a specification of quality control. That is there are many of them, and then among them, these are the key. So these are the, for instance, final culture supernatant, when we measure the cytokine, we measured many cytokines, but PDGF-BB has to be up and IL-8 has to be low, and cell surface marker and sodium potassium ATPase has to be positive, ZA1 expression has to be positive. And these cells we are injecting into the anterior chamber. So this is a representative records of the CPC production, C33 and C38. You could see we started from the 1 donor cornea. If we use the P3, so that we can make the cultured endothelial cells for at least for the 156 patients. If we could use the P5, we cannot at this point, but in the near future, we could do the P5. In this case, 1 donor cornea can create the cultured endothelial cells for over the 700 patients. So that this kind of procedure has some of the advantage, but I would say the most beneficial thing is probably the cornea without the distortion. It's more like a DMEC procedure, but we haven't touched to the desmoid membrane at this point. So I think the cornea without distortion, that is a fascinating thing also. Also, we would like to maintain the endothelial cell density as long as possible. Well, this picture I've already, and Mark already showed you, so that the giant of the EK surgeon here also, there are many, I think, EK surgeons. I don't want to compete with them. I'd like to cooperate with them. And then this is a kind of a supplement procedure, for instance, as I said, failed graft or so, and then beginning to expand the indicative disease as well. So that is our idea. And then this is the kind of summarized the slides. We started from the endothelial cells very difficult to proliferate and tried to inhibit EMT using the low kinase inhibitor. This is a main compound to promote this procedure, and we have a success of the cell expansion. And then making some of the minor modification or so, these cultured endothelial cells highlighted on the brown, these cells doesn't have any epithelial mesenchymal transition, so therefore safe enough to use these cells for the clinical research. And we performed 35 cases, and we've been negotiating with the Japanese Ministry of Health and Welfare for doing the clinical trial. So eventually, about just June 1st of this year, we got an approval of the Japanese Ministry of Health and Welfare for the clinical trial. So we're now making the cultured endothelial cells for the clinical trial, and takes about 4 months or so. So I think at the end of the September till the early November or so, we're supposed to do the phase 2 clinical trial in Japan. So the concept for the corneal endothelial cell therapy, I think a DMEC, it's a fascinating procedure, but we'd like to make some kind of additional treatment, surgical treatment, as I have already mentioned to you. But the other one is I haven't have a time to talk, but some of the eye drops that is quite effective for the acute injury of the corneal endothelial damage, so such as the low kinase inhibitor eye drops. I think that is also some of the treatment for the future. So I think I would like to acknowledge my colleagues also, and also because now we have to use many donated corneas. So I think we received a great support from the site. Well, thank you once again very much for your kind introduction and a kind of invitation. Thank you very much.
That's your medal.
Wow.
No silver, no gold for you two. But
Wow.
Really a great pleasure to have you here and to share your strong personality and great research. Thank you.
Thank you. Thank you.